Aspirants, this is going to be a very interactive session. The topic for today is trauma and burn, and it will be taken by Dr. Arun Thangavel, sir.
Thank you, Nidhi. Yeah, we have a small group of students today, but it's okay. We have an interesting session today. So I think last class we covered better about basics of trauma and burns, and I couldn't touch upon traumatic brain injury. So this session is going to be entirely on traumatic brain injury. So you are in safe hands again with Farz Academy. I can assure you with the Farz Academy classes and your preparation, you will definitely pass EDIC 1 so easily. So let's keep it interactive. This is going to depend on, the teaching is going to depend on your involvement and answering with the questions. So maximize your benefits by treating this like an actual mock exam and be involved. If possible, keep the videos on so we can interact better, and we will practice some MCQs along with the theory behind that. And at any point of time, feel free to interrupt and clear your doubts. So here we go. So what I want is either type in the comment in the chat box your answers so I can see it, and or else you can unmute yourself and answer yourself. Yeah. Fine. Everyone happy? So these questions we covered last time. So let's move on to trauma part, traumatic brain injury part. Yeah. This is our first question. 45-year-old male is admitted to the ICU following a severe traumatic brain injury, GCs of 6. An intracranial pressure monitor is placed. What is the primary goal for managing his cerebral perfusion pressure based on the current guidelines? Yeah, go ahead and you can type in the chat or unmute yourself and answer. Yeah. Nice. Yeah, it's pretty straightforward, right? 60 to 70 is the target font, which is correct. And this is for basically cerebral perfusion pressure is just the difference between your mean arterial pressure minus the intracranial pressure. In other organs, we subtract the central venous pressure, but for the brain, intracranial pressure is more relevant because it's a tight space and closed environment. Remember the Monroe-Kelly doctrine, so that's why we use intracranial pressure in this formula to determine the cerebral perfusion pressure. And the Brain Trauma Foundation clear-cut guidelines say the cerebral perfusion pressure should be between 60 to 70, which is ideal. In the management of a patient with severe traumatic brain injury, which of the following is a level 1 recommendation from the Brain Trauma Foundation? Yeah. Background noise. Ignore that. What's the level 1 recommendation in the given options? So level 1 is basically high quality evidence for those who are not aware. It's like based on systematic reviews and meta-analysis. Level 2 and level 3 is more like single randomized controlled trials or not clear-cut evidence available based on randomized controlled trials. Fahimudin says, hey. Any others, what do you think? Brain Trauma Foundation guidelines are quite important in the traumatic brain injury guidelines. and we should be well versed with the traumatic, all the recommendations from the Brain Trauma Foundation. It's really important for clinical practice as well as your exams. Yeah. So I agree with you, Hilal, and appreciate you are correct. It's C. It's the only, I mean, level one evidence. All the rest of the evidence are based on like small randomized control trials or consensus statements. So this is
Recording in progress.
corticosteroids. It's a definite no.
Corticosteroids, it's a definite no. Corticosteroids, it's a definite no. I'm just trying to log in from another. To log in from another. To log in from another.
It's difficult to see both the comments and words on the meeting, just the presenter mode, but it's fine. So yeah, corticosteroids is the right answer. Patient with severe traumatic brain injury is being ventilated. The ECM nurse suggests like hyperventilating for a bit, increasing the respiratory rate to drop the PaCO2 to 30 millimeters of mercury in an attempt to reduce the ICP. So what is the major risk of this strategy? Metabolic alkalosis, worsening hypoxemia, cerebral ischemia due to excessive vasoconstriction, increased cardiac output, and hyponatremia. Yeah. So it's understanding of the physiology, right? The cerebral blood flow is dependent on the CO2 levels. And if you see this chart on the right, so the green trace I'm showing is the PaCO2 and cerebral blood flow. You might have seen this on Miller's textbook of anesthesia. So the lower the PCO2, the lower the cerebral blood flow and the risk of cerebral ischemia. So you are all correct. Let's move to the next question. Patient with traumatic brain injury develops polyuria, more than 200 mL per hour of dilute urine and rising serum sodium and osmolality. So what is the diagnosis here? Yeah, I got all simple questions for you guys. Yeah, few tough ones, but you'll see in the end. Yeah, diabetes insipidus. So how do you treat it? How do you treat diabetes insipidus? Yeah. Yes, of course. Desmopressin, right? So if can the reverse happen? Can the patient develop hyponatremia with a traumatic brain injury? And what are the differential effects like hyponatremia? Yes, bang on. And yes, Abhishek, how do you differentiate cerebral salvating or wasting from SADH? It's easier to talk, you can unmute yourself, but I'm happy with the text. Yeah, just follow the chat box, everyone, because lots going on in the chat box. Yeah, it's very difficult to differentiate clinically cerebral salt wasting and SADH. Main thing is the volume status. So SADH is more kind of euvolemic, and the other is a bit of hypovolemia. And yes, as Abhishek says, that's the other factor, but it depends mainly on the volume status clinically. But I agree, it's difficult to differentiate most of the times. All right, let's move on. Which of the following monitoring modalities provides continuous information on cerebral oxygenation and metabolism at the bedside? Right, quite an easy question. I agree with you all. It's the C, which is correct answer. And just to refresh our, ICP monitoring techniques in a patient with suspected increased intracranial pressure, we have like different modalities, not one parameter, like one modality of monitoring cerebral perfusion is perfect. So we have like 5 different kinds. So we can use the intracranial pressure monitoring to assess the driving pressure, assess the blood flow using transcranial Dopplers, or oxygen delivery at the tissue level using the brain tissue oxygen oximetries and NIRS. And metabolism we can assess using microdialysis and CNS function and seizure activity.
Excuse me, sir.
Yes, yes, yes.
Voice is sir low. Voice is low. Voice is
Uh,
not clear. Oh, tone is low.
Sorry, Ilal, what was your
Sir,
question?
sir, voice is low. A bit. Yeah, yes.
Sorry, which one is low you are asking? Not able to understand.
Sir, audible. You are not audible properly. Tone
I
is
am
low.
not.
Yes. Yes, sir.
Okay.
Yes, sir. Yes, sir.
Yeah. Is it better now? I can come a bit closer.
Better, better. Yes, sir.
Okay, fine. Thank you. Thank you for telling me that. Yeah. Is it? I'll stay here, and I think you can hear me better now. Fine. So, microdialysis catheter is to assess the metabolism, and EEG you can assess the seizure activity. So, not we cannot just use one and say the patient ICP is normal and everything is perfect. Depends on the patient condition. We may have to use multiple modality, and just one modality is not perfect all the time. So we need to use all these modalities as based on availability, along with your clinical knowledge, and individual patient variability is always there. So no one modality is perfect. That's the main takeaway message. Okay. Cushing triad. What are the signs of the Cushing's triad? Hypertension, brady, irregular breathing, or hypotension, tachypnea, chain stroke breathing, hypertension, brady, and apnea, fever, hypertension, and nuchal rigidity. I will wait for everyone to answer. Okay, two of you have answered correctly. It is A, this hypotension, brady, and irregular respiration. We often forget the third part. So the third part is irregular respiration. Fine. This bit of a tricky question. Patient with confirmed basilar skull fracture should be monitored for which of the following delayed complication, except carotid artery injury, meningitis, hydrocephalus, cranial nerve 1 palsy, extradural hematoma. Interesting. But we are getting D as answer. What do the other think? Everyone try to answer. There is no negative marking here. And even for the EDIC exam, it's not a negative marking exam. So even if you don't know the answer, you can keep guessing. Nobody is going to judge you. So do get involved and answer, and try and answer all the questions in the exam. So don't leave any options, like any questions if you are not sure. Make a guess, make an educated guess. If it's right, you get a point. Otherwise, you don't lose anything, right? Fine. So interestingly, most of you say cranial nerve 1 palsy. It can be a delayed complication. Often we don't detect that unless the patient recovers and improves and well enough to detect like anosmia. So it manifests as clinically as anosmia. Like if you remember COVID times, many patients develop anosmia, right? So that can happen in as a delayed complication of basilar skull fracture. So that's not the right answer. And going to meningitis can always develop as complication, and hydrocephalus as well can be a delayed complication. Do you think carotid artery injury can be a delayed complication? It should be detected right away, right? If there is carotid artery injury. Interestingly, yeah, you can get a delayed, the carotid artery can get injured if there is a break in the wall or small hematoma. A pseudoaneurysm can develop, and it can cause late complications, maybe weeks or even years later. So there have been multiple case reports like carotid artery injury following basilar skull fracture, which wasn't detected in the initial few weeks and presented late. So that is a delayed complication. So I would have used a rule of exception here. Extradural hematoma is never missed out. Even if it's a small, thin extradural hematoma, it is picked up in the CT. So that is not a delayed complication. That is always detected acutely. So that is the answer. Yeah. Good guess, guys. All right. What is the recommended target for serum sodium concentration in a traumatic brain injury patient being treated with hypertonic saline for intracranial hypertension? So what is the recommended sodium concentration? Mhm. Yeah. Anyone else think otherwise? I've got few B's as the answer. Yeah. So most of you think B is the answer. That is the correct answer. So that is the recommendation from Brain Trauma Foundation as well. So try and avoid hypernatremia as well, just on the, like up to a maximum of 155. We don't want to go into the diabetes insipidus range and cause severe hypernatremia as well. And how do you maintain the sodium in the 145 to 155? Of course, we use hypertonic saline. Do you know any other modality?
Micro dialysis catheter.
We can monitor that, but how do you keep it in the 145 to 155? Interestingly, in my center, in one patient, we used like renal replacement therapy. Patient was having AKI, and we just changed the protocol to hypernatremia protocol and maintained sodium using that. We didn't use hypertonic saline, so that's one way you can do it as well. Cool. Coming to this question, a patient with TBI and an extraventricular drain in place for ICP monitoring. and CSF drainage, develop sudden headache, decrease in level of consciousness. ICP reading is only 5. Most likely explanation is ICP monitoring is malfunctioning, patient has improved, and the TBI is resolving. EVD may be clogged or kinked. Patient has developed diabetes insipidus. Patient is experiencing severe vasospasm. What do you think? We expect ICP to be high, right? But it's not. So what's happening? So here we have to troubleshoot the EVD, and likely, as you guys say, EVD may be blocked or kinked, and somehow it's not reading the correct thing. So similar to an arterial line or a central line trace, right? If it's not reading accurately, you just troubleshoot, adjust the position, and see if it's accurately reading. So that's what we have to do, and it's likely the EVD is not giving a proper reading. Okay, that was supposed to come with a click, but it's showing on its own, but it's okay. I will explain the curves, then we can go to the question. So this picture I added to just show you the ICP waveforms. So on the left, so this is time across x-axis, and along y-axis we have the pressure. So if you see up to 20, the C waveforms are kind of normal, and there is a normal variation in the intracranial pressure from like 15 to 20, even in normal patients. So this is absolutely normal. If you see B waves, so there are spikes in the intracranial pressure, like up to 30 to 40, and it drops back in the normal range. Again, there is a spike, and it's lasting for like few minutes every time. So this is a sign of increased intracranial pressure, and the patient needs some urgent intervention to reduce it. So even if the ICP is elevated, it can come back to normal, then again have a spike. So this can happen. And this is the worst of all, like A wave. There's a sustained increased intracranial pressure for more than 5 to 10 minutes. This is very detrimental, and the patient is going to die or become brain dead soon. So that's the Lundberg wave. This may be asked in the exams, even for part 2 of EDIC. And if you look closely into the intracranial pressure waveforms, it's similar to an arterial waveform, but it has got few more spikes. So the first spike is the systolic waveform, like first spike based on the patient's blood pressure. The second waveform is more significant. It represents the compliance of the intracranial vessels or the intracranial space per se. So if the ICP is elevated, there is going to be blunting of P1, and the P2 is going to be the peak of the waveform. So if this abnormal pattern, and it's suggestive of increased intracranial pressure, there can be a third waveform where P1 and P2 is merged, and that is suggestive of more intracranial pressure. So that is worse than B wave. And P3 is just like a dichrotic notch of the any arterial waveform. Happy with this? So now I'll go and take off these pictures. to show you question thing. Oh, great. So that's what I wanted to explain actually. For question. That's fine. Happy, any doubts with the intracranial pressure waveforms and Lundberg waveforms? Fine. Oops. I've already given you the answer, but it's a straightforward question as well. So why do we avoid fever in these patients? Because we are trying to avoid like secondary brain injury, right? Basically, that's what we are doing here. Let's move to the next question. Yeah, I wanted to discuss a bit about this. So for intracranial pressure management or increased ICP management, we follow a tiered approach, like tier 0 to tier 3. So are you aware of this tiered approach? You might have read somewhere, but the most recent guidelines, like consensus statement, was given by, and it's well written by the Seattle International Severe Traumatic Pain Injury Conference consensus. And this is nicely written. There's even a poster if you look into the civic guideline website. So there is even a poster which is well written. Please refer to that. So whenever there is increased intracranial pressure, patient with any traumatic brain injury or increased intracranial pressure due to some other reason, so it's ideal they get admitted to the ICU, have proper monitoring on, their dent is elevated, they are sedated, and we are aiming for like normoxia, normotension, normocapnia, prevent hypothermia, prevent fever more than 38, and get close monitoring, just do the routine housekeeping stuff, right? This is all the tier 0 approaches. And then the next level, if the patient is not responding, even after taking care of the basic maneuvers, then we escalate our management to like more invasive approaches. So we try and get an intracranial pressure monitoring. So then we can target our cerebral perfusion pressure, titrating our MAP and intracranial pressure, aim for a 60 to 70. Increase analgesia and sedation, see if that helps lower the intracranial pressure, and maintain normocapnia. So normocapnia is part of tier 1 approach. Avoiding like hyperventilation, it's further escalation. It comes in tier 2 and tier 3. And our medical management like hypotonic saline or mannitol or CSF drainage, EVD, all these come under tier 1. And avoiding seizures and fever, again, we should be more careful with tier 1 as well. So let's see another question. So the patient with severe traumatic brain injury has ICP of 30 to 35 millimeters of mercury despite maximal sedation and CSF drainage. So we have done the tier 1, right? Which next step is most appropriate? Decompression craniectomy, hypothermia, increase MAP to raise CPP, and initiate barbiturate-induced coma. Or do the others think? I've got a couple of decompressive craniectomy as answers. Do you all agree with that? Okay, so you all think decompression craniectomy. It's not wrong, but we can do something else in between. So the answer actually is increase MAP to raise CPP. So that is what we call a MAP challenge. So let's see what is map challenge. Yes, Abhishek, you are correct. So now moving on to tier 2. So if you see the tier 3 first, these are the extreme measures. Thiopentone coma, secondary decompression craniectomy, mild hypothermia. Note just mild hypothermia comes as an extreme measure. So hypothermia has no role at all in regular ICP management. This is based on recent evidences. Okay. So focusing on the MAP challenge, how does it work? So we are just testing the patient's cerebral autoregulation here. We are seeing by increasing the mean arterial pressure, what happens to the intracranial pressure, right? Let's go to this chart. It is better explained. So this is normal, 50 to 120 millimeters of mercury of cerebral perfusion pressure. Even if we increase the perfusion pressure, the cerebral blood flow from the y-axis remains constant. So we all have this physiology, right? In a traumatic brain injury patient, we don't know whether this cerebral autoregulation is intact or not. It may be or it may not be. That's why we need to challenge and see if they have an intact autoregulation by increasing the mean arterial pressure by noradrenaline or fluid bolus or anything. We are increasing the cerebral perfusion pressure, but because the cerebral vessels have that myotonic, like muscular tone, they vasoconstrict to maintain a constant blood flow, and so thereby, because the intracranial vessel or intracranial blood volume comes down, the ICP starts dropping. So remember, the intracranial space is a closed, tight space. So what are the components of it? Brain tissue itself, then cerebral blood vessels along with the blood, and it's encased by a skull, right? So once the cerebral blood volume comes down, the CSF automatically reduces, CSF pressure automatically reduces. So this is what happens in an intact autoregulation. So by increasing the mean arterial pressure, we are able to reduce the ICP, that way increasing the cerebral perfusion pressure, which is beneficial for these patients. Whereas in an impaired autoregulation, what happens is if we are increasing the mean arterial pressure, the cerebral perfusion pressure increases along with that, but the ICP is also increases. If the mean arterial pressure increases, the ICP also increases. So if we subtract the ICP from the mean arterial pressure, the cerebral perfusion pressure is going to get affected. It's going to drop eventually. So it's not beneficial in these patients. So that's why we should always do a mean arterial pressure challenge and monitor all the parameters, including brain oxygen consumption, to see if it's beneficial or not. If it's not beneficial, it may be harmful. You should try and avoid that. So that's why it's dangerous just to maintain increased mean arterial pressure in a patient with increased intracranial pressure. Is that clear? Any doubts, or do you want me to repeat it? Just let me know. Otherwise, we will move on. And the other tier 2 measures. So mild hypocapnia comes under tier 2. So far we were under tier 0 and 1. We are maintaining normocapnia here, mild hypocapnia. Mild hypothermia comes only in tier 3. So you have a clear picture now. So on similar lines, next question. So a patient with severe traumatic brain injury found to have pressure reactivity index persistently positive. So what does this indicate? This is kind of an advanced neurocritical care. So I don't expect you to know that, but if you know, just make a guess based on what we have discussed. Then we can discuss what's pressure reactivity index is. Take a guess, be bold. There's no negative marking here. Yeah, we have guessed. Come on, Abhishek, what do you think? Fahim and Lal. Okay. So based on what we have discussed, it's similar story, just the terminology is new. The pressure reactivity index. This is the answer, but I will go back and explain. So it means if it's positive, it means impaired cerebrovascular autoregulation. So if you see the impaired autoregulation, so the mean arterial pressure increases, the ICP is increasing, right? So this has a positive correlation, which means impaired autoregulation. So that's what the next question is about. Pressure reactivity index, if it's positive, it means by increasing the mean arterial pressure, your intracranial pressure is increasing, which in turn means impaired cerebral autoregulation. Normally, if the autoregulation is intact, the ICP reduces, right? So that's a negative correlation. So in normal patient, the pressure reactivity index, it is basically a value given by the monitor, which gives the ICP and like mean arterial pressure. It reads out the value. If it's in the negative, it's normal. But it's positive, means impaired cerebral autoregulation. And it's not a linear correlation, even in patients with normal cerebral autoregulation. So up to a level, if you keep increasing the mean arterial pressure, the ICP comes down. Then after that, like beyond 80 or 90, if you keep increasing the mean arterial pressure, going to increase. I mean, the ICP is going to increase even in a normal patient. So that's why it's a U-shaped curve. So we need to find the sweet spot in, it can vary like plus or minus 5-10 millimeters of mercury in different patients. So we need to find the spot and make sure whatever intervention we are doing, it's actually reducing the intracranial pressure. Again, so this is where the upper limit, if we keep increasing even with normal autoregulation curve, we keep increasing the blood pressure, the cerebral blood flow eventually will increase and cause more intracranial pressure. So that's what we don't want to have and find this optimal cerebral perfusion pressure. So that's the importance in this question. Is that clear? Do let me know if I need to clarify a bit more. Fine. Let's go back to some simple questions. Hyperosmolar therapy with hypertonic saline compared with mannitol offers which advantage? Basically, why it's better than mannitol? Why hypertonic saline is better than mannitol? Is it B or D? Fahim. I think I'm calling you correctly. Fahimuddin. Yeah. Is it D or D? So answer both. D. Okay. not an absolute contraindication, but it's kind of relative contraindication, I would say. Yeah. What are the other things? Oh, we have a new customer. B, yes. So I think general consensus is B. For him, then your first answer was correct. Don't change your answers in the exam. So yeah, hypertonic saline, it is a diuretic. Mannitol is an osmotic diuretic, right? So it causes hypovolemia. That's how it acts. But hypertonic saline is like a volume load, sodium load to the patient. So it, by nature, by its mechanism of action, it improves the intravascular volume. Otherwise, mannitol can cause hypotension if the patient is in like euvolemia or hypovolemia already. So that's one reason we prefer hypertonic saline in these patients. And hypertonic saline is more effective, and especially you need to avoid mannitol in patients with impaired autoregulation because it can break the blood-brain barrier and go into the brain tissues and cause reverse osmosis and can worsen intracranial pressure. If the blood-brain barrier is not intact, mannitol can cause worsening of intracranial pressure by leaking out into the tissues. So that's something to be aware of. Fine. Traumatic brain injury and ARDS. Patient is having both. It's not uncommon situation. A polytrauma patient can have lung injury as well as brain injury. So they have developed ARDS somehow. So which ventilatory target avoids worsening intracranial pressure? Using peak titration table from EDIC net protocol, allow permissive hypercapnia as per the ARDS routine, deep sedation with PSC equal to around 50, aim normocapnia. So how will you change your ventilatory target in a patient with both traumatic brain injury and ARDS? Yeah. Most of you think D. I agree with you. It's not always possible because of severe, if the patient is in severe ARDS and requiring proning and all. It may not always be possible, but that is the aim. We don't have clear evidence or guidance from any societies regarding this, but what we know is increasing the peak is going to increase your ICP, or increased intra-abdominal pressure is going to increase your ICP, or hypercapnia is going to increase your ICP. So we are trying to avoid intracranial pressure, protect the brain more than anything. So aiming normocapnia seems to be the right answer here. Fine. We are coming to the last few questions. The severe traumatic brain injury patient has neuroworsening. He has normal ICP, normal CPP with brain oxygen saturation like 10 and normal systemic oxygenation. So what is the next best step? So the term neuroworsening as a definition given by the Seattle Society, like consensus statement, go read that. So they've given a definition so that there is some uniformity across the studies which are done based on severe traumatic brain injury with deterioration. So what do you think is the next best? let me tell you a clue that brain oxygen saturation is very low. Patient is normal ICP, normal cerebral perfusion pressure, normal oxygen saturation in the systemic circulation, but the brain oxygen saturation is very good. What is the next question? Hyperventilation, sedate and paralyzed, hypertonic saline, EEG, or non-convulsive status. I'm getting B from a couple of you. Or to the other thing. This is EDIC is more like a clinical exam. Most of the exam questions will have direct clinical application, which if you have worked in ICU for a few years, it's going to be an easy exam to pass. So let's discuss the options here. Hyperventilation, it does see all the tiered approaches like tier 0, 1, 2, 3 are for patients with raised ICP, right? But here our ICP is normal. So we are missing something, right? Patient has deteriorated, but the ICP is normal. So one reason for, Nidhi has got that right. So one reason for excessive oxygen consumption. So that's what happening, right? So brain oxygen saturation of 10, normal should be more than 20. With 10 off of that, it's very low. It means the brain is consuming more oxygen. So what causes brain to consume more oxygen? So seizure activity is one of the main things. Other thing is hypothermia or fever, which is systemic. We will pick that up easily. And if the patient is having obvious seizures, that's easy to pick up as well. But we can never rule out non-convulsive status epilepticus just by clinical assessment. And if there is neuroworsening, that's we need to do an EEG to rule that out. So we take that out of the equation, right? So that's why that is the right answer. The brain is consuming more oxygen because it's more active due to non-convulsive status epilepticus, and that's what we do an EEG and treat the seizures if there is evidence of seizures. Okay. Which cerebral microdialysis pattern most strongly suggests mitochondrial dysfunction or ischemia? Low pyruvate lactate to pyruvate ratio of 25 with high glycerol, high lactate to pyruvate ratio with low pyruvate, high glucose with low LPR, low glutamate with low LPR. So to answer the question in the chat for Raj, all sedatives are not anti-epileptic. So anti-epileptic option is more like focused answer rather than just a blanket statement of sedation and paralysis. So that's why EEG to rule out non-convulsive and treat it with anti-epileptic will be a better choice. Step back. Sure. Take a guess. You don't need to understand microdialysis. You can just try and understand what happens with lactate and pyruvate. Even in the systemic like sepsis, what happens? Just take a guess with that understanding of physiology. You don't need to know microdialysis to answer this. Yeah. Yes. Abhishek has got it right. Kasi is right as well. So it is high lactate to pyruvate ratio with low pyruvate. Because the brain is having mitochondrial dysfunction, there's anaerobic metabolism going on, and that's why your lactate is going up, and pyruvate, which is the normal end product, gets converted to lactate instead. So, and the numbers to remember here are like 40 and 25. So more than 40, it's abnormal. Less than 25 is normal. And this will be our last question. And I have one more slide to just review, summarize the intracranial pressure monitoring. The patient with traumatic SAH has developed hemiparesis. Doppler shows mean middle cerebral artery mean flow velocity of 210 centimeters per second with an elevated Lindegard ratio more than 6 after traumatic brain injury. So what is your interpretation? So why did the patient develop hemiparesis after having a traumatic SAH? Come on, others, have a go. This is the last question. We're not losing anything. Yeah. So it is a severe vasospasm. So transcranial Doppler, any of you had a chance to do transcranial Dopplers? So we are getting more and more awareness and training in the conferences, right? With transcranial Doppler, it's a effective bedside method to assess the blood flow across various vessels in the brain, especially the middle cerebral artery is quite close to your lateral temporal bone, and it's well aligned to your Doppler signal, so we can get a good view and good accurate measurements. And it's quite key for especially subarachnoid hemorrhages to assess for vasospasm. We can do serial assessment to look into the middle cerebral artery flows and see if there is like vasospasm. So how we do that is, so we first try and find the middle cerebral artery, the circle of Willis, by putting a probe across the temporal window. And once we visualize that, we can put a pulse wave Doppler so that we can sample that middle cerebral artery accurately, and we'll get a trace like this. So we get a mean flow velocity by making a trace of that waveform, and we can compare it to the carotid artery waveform on the same side. Then that gives the Lindegard ratio, and it's more than 6. It's a sign of severe vasospasm. The patient needs urgent intervention. So we will alert the neurosurgery team or the interventional radiology team to go back and give some intra-arterial nimodipine. So usually we give these patients like nimodipine to prevent vasospasm. On top of that, they may need like catheter-directed delivery of nimodipine, which might help. And yeah, subarachnoid hemorrhages usually have poor outcomes with severe vasospasm. Most of them end up dying or having severe like neurological deficits in it. So it's vital we monitor them using transcranial Dopplers if there is any deterioration. Even otherwise, outside like intracranial subarachnoid hemorrhages, transcranial Doppler is a very important tool through which we can monitor the intracranial pressure. So what we can see is the pulsatility index, the difference between the C's peak and the diastolic. If it's like too wide, if the diastolic blood pressure is very low, in the diastolic mean velocity is very low in the middle cerebral artery, it's a sign of increased intracranial pressure and decreased compliance, right? So I like transcranial Doppler very much, and it's a good technique to know. So to summarize, the multiple modality, these are the numbers you need to remember basically. There is no other way. And you should understand each technique and the significance so that you can, if you get and it's easy to answer these questions once you know what it is. So don't miss out if you get any questions from intracranial pressure and monitoring. So cerebral perfusion pressure, we are aiming for 60 to 70. And if it's less than 60, we should try and act and do some intervention to make it better. Intracranial pressure, if it's more than 20, that will be our threshold. And cerebral blood flow, we can assess using transcranial Doppler. And these are the mean velocities across different arteries. For MCA, for anterior cerebral artery, this is posterior cerebral artery. And if it's more than 200, like in our last question, it's more than 200, it's suggestive of vasospasm. Even if we don't do the Lindergaard ratio, we should treat it like severe vasospasm. And if it's more than 6, it's severe vasospasm. 3 to 6, it's like mild to moderate vasospasm. Less than 3, it's normal. And venous oxygen saturation. So there are multiple ways to assess cerebral oxygenation. We discussed cerebral direct catheter-based monitoring. That's the value given by this. If it's less than 20, it's severely impact. And sometimes we do jugular venous oximetry, where the normal value is 50 to 80. Either of the other extreme is abnormal, like mixed venous saturation, basically. If it's less than 50, we can try and improve the perfusion or oxygen delivery. If it's more than 80, it means that there is mitochondrial dysfunction. Basically, the brain cells are not consuming enough oxygen. And cerebral metabolism, we can assess using the microdialysis catheter. We can have multiple parameters to look at. Glucose, the normal values are these. Lactate, if it's more than 3, it's abnormal in the brain. And the lactate to pyruvate ratio, normal is less than 20. More than 40 is significantly elevated and suggestive of ischemia, ongoing ischemia or hypoxia. Glutamate and glycerol, if it's elevated as well, it's not a good sign. It's a marker of ischemia. So I think that's the gist of intracranial monitoring, and I don't think you can get any more questions out of this. If you have any questions, I'm happy to answer. Or if you want to review anything else. Everyone happy? Hope the class was useful. To give feedback, and all the best for the exams. You can end the class now if you don't have any questions. Is there any book we need to follow? For critical care, it's getting updated quite rapid pace, right? So I think the best way to go about is for the MCQ exams, there are multiple books there. You can just stick to one, at least try and finish one MCQ book. I didn't do any MCQ book, to be honest. I just read the topics and gave the exam. But it's always good to have some practice and try and finish all the questions in time management, basically. So that's more important, attending all the questions and answering all the questions. Make a guess even if you don't know. There's no negative marking, as I said. And keep, for each topic, we need to do our own research. There is no one place where all the details are there, all the information is there. So we need to chase the guidelines. If there is any new updates, we need to keep our own notes. And Farz Academy has so many materials. So if we complete that much, that's more than enough for your exam. All right, guys. Thank you so much for attending. Is ESICM modules need to be followed? I would strongly recommend ESICM modules. It is time consuming. There is a lot to read, but it's a good material, especially for important topics like CRRT, kidney injury, trauma. I would strongly recommend to read the ESICM module, and you will get questions for EDIC part 2 as well. So yeah, if you have time, please do read the ESICM module. Okay, guys, let's end the session then. Thank you so much for attending. Hope it was useful.